It is my great pleasure to be here, and yes, I'm Anna. I work in Sofia in Bulgaria in the University Hospital of Alexandrovska, and I would try to summarize some of these topics that were mentioned, speaking about classification and nomenclature of angioedema conditions. But I think the most interesting part would be the one that I would like to share some insights and some clinical experience for differential diagnosis of these conditions. And when speaking about angioedema, we can, I think with full heart, all of us, we can say that the essential thing is not visible with the eyes. So it is only with the heart that we can see what is underlying the condition, like in angioedemas, because very often we don't see what is superficially presented as a condition just with the swelling. So we might have patients that look alike quite the same, but really the underlying condition is very different, and it is with the heart that we can actually see what is inside. Surely we need classification in order to be able to understand what are the various subtypes made of and what are the characteristics that bestly define them. And also we need nomenclature in order to be able to easily translate what we want to say to other physicians when speaking about this condition. So the first classification and the pivotal consensus of Professor Marco Ciccardi and the group of the International Hereditary Angioedema Group, the so-called HOGE guidelines, they were established exactly 10 years from now, and they were the first and extensive evidence-based foundation to identify all forms known at that date, including the incidence, the clinical presentation, the pathogenesis, diagnosis, and also giving advice about the treatment of the various subtypes of angioedema. So the idea here is not to substitute the old consensus or what we had as a existing classification, but to update it and to adapt it to the modern understandings of, that we now currently have about various subtypes of angioedema. Also, we need a unified nomenclature in order to be able to speak the same language. I bet you would agree that maybe explaining angioedema with hundreds of words is not very useful, but when you give the identification of a specific acronym, this helps a lot. And again, the whole group was the first to formulate all angioedema-specific vocabulary and acronyms, also forming this taxonomy of acronyms to help us better identify the conditions easily. So this is how the DANCE project was born, and this was something that was a call for an updated, comprehensive, and widely accepted classification system to combine clinical expression, pathomechanisms, biomarkers, but also known, newly understood genetics that were incorporated of some specific HE types. And this was a global consensus formed to identify what would be this call for update of the classification. So the DANCE project is a NACARE project, including 91 experts from 35 countries, which represented 53 scientific societies. So the news here in the definition is not very surprising. There is just a slight difference from the previous one. We have this new definition that is angioedema is a paroxysmal, localized, and self-limiting swelling of the subcutaneous or submucosal tissues, and it is due to a temporary increase in vascular permeability. Here we have the dropout of recurrence, because sometimes we know very well that angioedema is just a single episode, so paroxysmal replaced it in the definition. The updated nomenclature, as you will see, looks into the definition firstly about whether we have angioedema or whether we have hereditary angioedema, and just with a single dash looking into the mechanism, biomarker, and genetics that might be underlying the condition. For example, the C1 inhibitor HAE is now stated as HAE-C1 inhibitor without the dash, while the only acquired form is kept for the acquired angioedema due to C1 inhibitor deficiency. Only here we keep the AAE as an abbreviation. While the others that they're newly discovered mutations, they also come after identifying that this is HAE, and this is the most important part. So this is how the new endotype-based classification will look like. The paper is underway. It is submitted for co-publication in JACI and Allergy, still not public, but we can speak about this classification most probably because this would be the next steps of identifying angioedema conditions. So we have 5 endotypes: the mast cell endotype, the bradykinin-mediated, the one with intrinsic vascular endothelial dysfunction, the drug-induced one, and we also have the type that is kept historically as an unknown angioedema. So here we have room for improvement, and probably this is a heterogeneous entity, as we all know, that would probably stratify to other conditions in the future. So the endotype of mast cell activation, this is the horse of our angioedemas. This is the most frequently observed angioedema type due to release of mediators from mast cells. It replaces histamine-mediated, histaminergic, allergic, or anaphylactic, because we are not very sure whether only this mediator is capable of inducing the condition. This is a patient that I had presenting maybe with one of the most presented histamine angioedema. This is a patient with urticaria angioedema. So here you also have patients with urticaria and also the patients with anaphylaxis. This endotype not all the time answers to high doses antihistamines. That's why we decided not to put histamine in the definition. Sometimes those patients benefit from omalizumab. The next endotype is the bradykinin-mediated angioedema type. Here we have the classical presentations of the one that we know best, the HE due to C1 inhibitor deficiency, types 1 and 2. But we also have here the acquired angioedema with acquired deficiency of the C1 inhibitor protein, and also the HEs with normal C1 inhibitor reflecting to the genotypes of factor 12 plasminogen and kininogen mutation. So the expert group agreed that there is plenty of evidence to support that these subtypes, these genotypes, they are due to bradykinin stimulation. So, but if we are thinking about genetics, of course, we should refer to the international consensus. I've heard from Professor Germanis, probably in the next years we will be having also a revision here. But when speaking about HE with normal C1 inhibitor, genetic test is something that we need to be able to perform. The next endotype is the vascular endothelial dysfunction endotype, the one that looks into the genotypes of angiopoietin mutation, myofurlin, and heparan sulfate. I'm not sure where the newly discovered one would go. Carboxypeptidase, it would be probably in the bradykinin group, the one that was published just recently. But we have the localized endotype with these genotypes of HAE. Due to abnormal angiopoietin 1, for example, with angiopoietin 1, here we have the type 2 receptor disequilibrium and predominantly VEGF stimulation. We have the myofurlin mutation, which accounts for abnormal myofurlin synthesis and also this signal pathway, and the heparan sulfate, which was debatable where to be exactly classified, but the group actually agreed to put it here in the vascular endotype. Vascular endothelial endotype. Something else that was added to this endotype of angioedema conditions was the systemic capillary leak syndrome, which is a generalized condition. It is a potentially fatal disorder that is characterized with severe episodes that might be causing severe hypotension, hypoalbuminemia, failure of some organs, muscle necrosis due to the compartment syndrome, and also life-threatening multi-system failure. So these episodes often come suddenly. They are preceded sometimes by aura or increasing in weight of the patients, and there is no recognizable biomarker, though most of the patients actually they present with monoclonal gammopathy of undetermined significance. So this is a rare condition. Most of the episodes resolve spontaneously, and the most important part is people not to be harmed during these episodes because their endothelium is basically refractory to any kind of treatment. So here we should not harm our patients. I don't know if you have experienced such patients in Greece. in Bulgaria, as far as I'm aware, there are no recognized patients with this condition. So the next endotype is the drug-induced endotype. A lot of discussion was formed here throughout the group, because some drugs, they actually attribute to worsening of some angioedema conditions, but some drugs might be also the only thing that cause the condition. So without the drug exposure, patients do not have any symptoms. So we discussed whether to be drug-induced or drug-exacerbated, and I believe there is room for both. Because some conditions actually just exacerbate under drug treatment. So we have the drugs that modify the renin-angiotensin-aldosterone system. Here we have the ACE inhibitors, also the DPP-4 inhibitors. The incidence of those conditions increases with age in smokers and also in African Americans. And we also have the group of arachidonic acid modifiers, which worsen maybe 30 to 35% of patients with chronic urticaria, and we might see single or multiple reactors here. We know very well that estrogens also exacerbate some kinds of HAE. So the drugs implicated in angioedema are listed in this graphic, and you can see that patients very often, they tend to present with angioedema of the upper airway, so maybe an intervention of the airway might be needed in those cases. What I think is quite new and for the first time maybe stated, that patients with ACE inhibitor-associated angioedema are not contraindicated for initiation of certain treatment. So that is most probably something that we will have the possibility to keep when discussing for our patients whether we can try these therapies or no. And the last endotype is a heterogeneous one with unknown cause. The expert panel recommends that patients diagnosed under this category need to be regularly reevaluated and given the best of care, even though some cases might need to be offline, off-target or off-label users of HAE therapies, and this would be correctly stated in the consensus. Here, under this unknown endotype, the group decided to categorize also the episodic angioedema with eosinophilia. So this is the so-called Gleich syndrome. This is something that also, as far as I'm aware, in my country has never been diagnosed. Another rare condition that is poorly defined with unknown pathomechanisms, and even Dr. Gleich, who discovered the disease, he cannot say, and he knows a lot about eosinophils, so he's a specialist in eosinophils, but he says that there is no plenty of data to support that eosinophils are causing the condition. There are some data that attribute mast cell activation as well. So currently the Gleich syndrome would be categorized under the unknown type here. What is important for the definition is that most of times we have this triad of angioedema, eosinophils, and high IgM levels. So it would be easy if we all have the classification, and if the patient enters the room with the label that this is this kind of angioedema or the other. But surely we need a lot of experience, like in haute cuisine, to identify what are some of the conditions that doesn't need to have anything to do with angioedema. So in this second part of my presentation, I would be looking into some angioedema-like conditions. And differential diagnosis might be a challenging story in the office of an allergist. Something that we also, and I'm so sure that all of us encounter in the clinical practice, are patients with contact dermatitis that are referred with angioedema-like condition. We have this characteristic presentation on exposed areas of the skin. Patients very often have the very specific history of exposure to a certain agent, and they might have a good clinical course if not exposed again to the culprit agent. Those patients very often have also, of course, engagement of skin surface that was exposed to the agent. Some other patients present with an outcome that was not very planned. After dermatocosmetic procedures, the facial fillers, maybe you've seen patients who decided to augment their vision with different kind of fillers, and the result is not that desirable at the end. This might be also mistaken for an angioedema condition. Another group of patients are those that do not have a history of exposure to specific agents, and they have idiopathic swelling of the lips very often. We have the Melchior-Rosenhaus syndrome with the granulomatous cheilitis of Mischer, one of the triads to establish the diagnosis. Another is the lingua applicata and also facial paralysis. So most patients present with the three of them. It is typical to have the young age onset, but also older patients might be affected, like here. So these are two patients that I followed. Corticosteroid treatment is the one that might be worthy, and diagnosis is established through histopathological evaluation. Another maybe more rare condition, this is also a patient that I followed some years ago, is the Morbihan disease or morbus Morbihan. This is chronic facial edema associated with rosacea and acne, and you can see the face of the boy that he showed me when he went to the office, and he continuously started to worsen with chronic progressive non-petic edema of the upper two-thirds of the face, notably the periorbital area, but also the glabella and forehead, nose, and cheeks. Male patients are more commonly affected by this condition. It is often refractory to treatment. Actually, this patient had the Morbihan disease associated with acne, so he was initiated on retinoid treatment and actually continued to improve after this initiation of treatment. And the condition, it is named after a physician who discovered it in French Brittany in France. Another edema condition may be more easily to identify because of the characteristic look of those patients is the DRESS syndrome or drug-related eosinophilia with systemic symptoms. This is a presentation of a severe cutaneous adverse reaction to a drug. Very often the onset is with an acute macular papular rash, which usually develops up to 2-3 weeks after initiation of a culprit drug. The most commonly susceptible drugs are allopurinol, but also some non-steroidal drugs, benzodiazepines, and antibiotics. We have facial edema in most of the cases, which is usually in the periorbital area, but it can be also the entire face. We have high fever and abnormal liver enzymes. Spontaneous flare-ups are very typical after maybe 2-3 or even more months after the discontinuation of the therapy, and unfortunately mortality rate is around 10% from this condition. So another condition in our differential diagnosis palette is this is a patient that I had 2-3 years ago. He was 11 years old then, and he presented with recurrent angioedema for around 1 year before starting to present also the vasculitic rash. He was later diagnosed with hypocomplementemic urticarial vasculitis. He had conjunctivitis and abdominal pain upon flare-ups, some of the flare-ups, but initially the condition was only angioedema. He barely answered to treatment with corticosteroids, so high doses would help. And he had low C3, low C4, and low C1q. C1 inhibitor was antigen and function. They were both normal. And there was a discussion whether this patient is a lupus patient. And I found this from the literature. You can see angioedema presents in HUV in around 72%, while for lupus patients it is in less than 5% with angioedema. So currently this patient, unfortunately, he needed to initiate also cyclosporine therapy, but he's doing well under this immunosuppressive therapy. The next condition that I decided to put in this palette was the Muir disease. Very recently we had a patient, an adult patient with this congenital condition. So this is type 1 congenital lymphedema, which is a non-syndromic primary lymphedema caused by autosomal dominant mutation in the VEGFR gene. The symptoms usually present in young age, so it might be a diagnostic problem for children most of all, because they tend to have improvement of the symptoms. So the patient that I saw was maybe a little bit older than me, and she had edema of the limbs, which was lymphedema, non-reversible one. But children, they can have reversible edema, and this might be causing problem with the diagnosis. The onset of symptom is usually in young children. You can have affected all of the throughout the body, and the edema is pitting like in lymphedema. Another condition which might be misdiagnosed for angioedema is the superior vena cava syndrome. I bet that all of you have seen such patients that have suffered. This patient actually is a patient of my colleague Maria Stavska. So she came to the clinic after maybe 6 months of continuous corticosteroid therapy. That a little bit helped, but she was diagnosed with allergic edema of her right arm only. The cause very often is a thrombus or a malignant tumor that suppresses the draining group of the superior vena cava, and the condition can be unpredictable because if a thrombus is there, the patient might suffer a severe an acute accident when the thrombus is ruptured. This patient underwent endovascular procedure, and now she's currently doing well. Other cases might be associated with malignancy, and the delay of the diagnosis is the most problematic one in this condition. And this was a patient that we thought that was superior vena cava syndrome. Again, he had edema here of the upper thorax and the face, and it was poorly answering to treatment with corticosteroids. He had muscle weakness of upper and lower limbs, which we neglected as a symptom somehow in the beginning. He had a history of urothelial carcinoma, and he was surgically treated for the condition in 2020. And from the CT scan, there was bilateral thrombosis of the vena jugularis interne, and he was referred, therefore, for the cardiology clinic. They tested for creatinine phosphokinases, and actually he was diagnosed with dermatomyositis. So this is a condition that most of all dermatologists would recognize much easier than allergists. So we didn't do the best of our knowledge. We did what we could at that time, but actually it was not superior vena cava, but dermatomyositis. And this is also another case that was very curious for me. This young man, also a patient of Professor Stavska, he came with an intermittent edema. You can see where here the eyelids, without provoking factor. He didn't have any symptoms, no itching, no pain, nothing. He also had swelling here in the forehead, which is not seen very well from the picture. And sometimes he had swelling in the parietal area, again on the head. The edema was often asymmetrical and presented usually in the mornings. And here the history actually of the last 6 months that he had revealed what was the condition. He had the edematous tissues over the cranium where areas of recent surgical treatment actually had taken place. He had a trauma with a motorbike, and he had a trauma of the frontal, nasal bones, and orbitae. So when we referred him to, because he was referred with allergic angioedema to our clinic, when we sent them back to the neurosurgery, they discovered that he had osteomyelitis, and a very long course of antibiotics helped resolve the condition. Another iatrogenic iatrogenic condition that can be observed is the subcutaneous emphysema. It is a rare complication of various invasive procedures like endotracheal intubation, but also ENT procedures, a lot of endoscopies, bronchiolitis, but also dental procedures in rare cases can cause it. Severe asthma episode can cause it as well. COVID-19 patients have been described to present with spontaneous subcutaneous emphysema. The condition can progress rapidly, which mimics for some physicians histaminergic angioedema. Here the physical examination helps a lot because there are crepitations of the skin. And the prognosis is excellent if it doesn't progress more, because if the progression is more severe, we can have pneumothorax or pneumomediastinum, which might be severely affecting the life of the patient suddenly. The next iatrogenically induced condition that I put in the group was the ovarian hyperstimulation syndrome. So this is a condition with which is a complication of assisted reproduction. It is associated with capillary leakage and also compartment syndrome, so it is very close to the systemic capillary leak syndrome. Usually gynecologists are aware, but the main idea here is to avoid this condition because it can be very deleterious and fatal to the patient. That's why frozen eggs usually are advised to be transferred to patients under in vitro fertilization. And all of the symptoms in capillary leak, we can see them: hypovolemia, effusions, hemoconcentration, compartment syndrome, coagulation abnormalities and thrombosis, and thromboembolic events as well. And such systemic capillary leak syndrome has been also described with some viruses. For example, Maripa virus in French Guinea. I don't know exactly a lot of stuff about this virus. Some hantaviruses, COVID-19 virus, and also others. Vector and RNA vaccines, bone marrow transplantations, and also T-cell targeted therapies are. This is a non-exhaustive list. They can cause systemic capillary leak syndrome. So if I try to summarize, edema states are frequent and they are a cause to seek emergency in up to 1 of 3 emergency visits. The diagnosis remains a challenge for a variety of cases and very often might require a multidisciplinary approach. Our evidence-based, endotype-based classification, and that would be published very soon, look to a homogenized nomenclature of angioedema conditions to help improve diagnosis of angioedema. And I would like to quote Mahatma Gandhi, who says that the correct diagnosis is 3/4 the remedy. I think that you would agree with him about angioedema. And with this, I would like to greet you for the beginning of the pollen season. I see enthusiastic faces ready to treat patients with pollen allergies. And this is the Bulgarian Martenice, which is a symbol that we give as a present to all our friends on the 1st of March. And it is believed to protect you and to give you health. So I'd like to virtually translate this to you and to thank very full of my heart to Professor Germanis and to Dr. Psaros and to Dr. Tseli for their friendship. Thank you so much.
Thank you for a fantastic talk, very comprehensive. So make things difficult for everybody. Any questions? So let's give him a couple of minutes to warm up. I would like to ask a couple of questions. Let's start with the mast cell-mediated angioedema. So it seems that the only way to diagnose this entity is to administer omalizumab, correct?
This is a great discussion, yeah. I think all of us try antihistamines. I don't know how is the situation in Greece, but in Bulgaria you cannot give omalizumab that easily. So we try all of the times with antihistaminic drugs.
So that gives me the opportunity to ask you a second question. So in the very rare entities dealing with the endothelium dysfunction-oriented angioedema, we have late onset presentation of the first signs and symptoms, although there are genetic disorders. So which is the explanation for this? I mean, it complexes the differential diagnosis.
Yes, indeed. I don't have the easy question. The short question, I don't have an answer for this. Very recently, I was challenged by a patient who has HE with C1 inhibitor deficiency, a type 2-1. We proved it in his son, also in his brother, and in his father. He had, all of them have low C1 inhibitor function, and they presented with angioedema. And these men came to the clinic after a history of airway edema in July 23, when he was at the age of 63. And he had a history that he was exposed to ACE inhibitors for a duration of 6 years in the past. So I don't know. I cannot answer to your question, but I cannot also explain this case to myself. Very late onset, his son is 20-something, and he presents with angioedema. But the father was asymptomatic, even under ACE inhibitors, with an onset at the age of 63. So we really don't know.
That's interesting. So, any other questions? Yes, please.
Hi, thank you very much for the presentation. My background is
Μπορούμε να έχουμε το μικρόφωνο λίγο.
So apologies if this is a genetics derived question, but I was wondering how often in the clinic do you use genetic testing for diagnosis or differential diagnosis?
So in my clinic, unfortunately, we do not have regular access to genetic testing. We've completed maybe the biggest study among Bulgarian patients with the help of Professor Germanis some years ago. And recently we had the possibility also to collaborate with a colleague from Spain. So this is something that we did, but it is not something that we can usually regularly access for every patient. I did the test for this one that I mentioned, and there was a mutation that was found.
Professor Germanis, yes.
I would like to inform you that the A-Care schedules to offer for free genetic testing for angioedema patients. The project will start next month. Worldwide.
Yes, it was announced. And currently there is a project for unknown HAE. For unknown angioedema, there is a project with whole exome sequencing that also is accessible for A-Cares. But we don't use it on a regular basis.
Okay, that was great. Thank you so much.
Thank you very much.